Welcome to the Metabolic Link, a medical and science-focused podcast that explores the common thread of metabolism in health and disease. This is where science meets society. Welcome to today's episode of the Metabolic Link. I'm your host, Victoria Field, and I'm the co-founder of Metabolic Health Initiative, which is the overarching organization to the scientific conference Metabolic Health Summit, this podcast right here, and the Metabolic Initiative, which is our medical education platform dedicated exclusively to metabolic health and therapy. It's open to the public as well, and you can find more information and just a robust library of resources there at membership.metabolicinitiative.com. So certainly head on over there. But today, I am so honored to introduce our guest to you. It's Dr. Philip Ovadia, and he is a renowned cardiac surgeon who is also the founder of Ovadia Heart Health and the author of the acclaimed book, Stay Off My Operating Table. Dr. Ovadia has actually performed more than 3,000 heart surgeries and is deeply committed to revolutionizing heart disease prevention through metabolic health. His personal journey is actually equally inspiring. He's lost over 100 pounds. He struggled with obesity for most of his life, but he's actually been able to keep that weight off through dietary and lifestyle changes. And now he is dedicated to sharing that message and what he's learned along the way, both from his personal journey and his journey as a cardiac surgeon. Today, he's going to share insights on achieving optimal heart health and staying off his operating table. Before we dig into this interview, I want to say a special thank you to the sponsors of this episode, Genova Connect, Maui Nui, and ZocDoc. Now, if you're tired of going out to the lab to get blood work drawn and you really want to take your own metabolic health into your own hands, head on over to Genova Connect. Genova Connect is powered by Genova Diagnostics, and they offer advanced lab testing right in the comfort of your own home. It's such an amazing convenience, and the people behind Genova Connect are truly thought leaders and leading the charge when it comes to optimizing metabolic health as a whole. They offer a wide variety of testing, from gut microbiome testing to nutrient assessments, hormone assessments, you name it. You'll have to go take a look at all of the tests that they offer, but these tests really give you a clear picture of your health. If you're wanting to reach health goals, it's always great to get a baseline of a wide variety of things, whether it's nutrient deficiencies. That's super helpful to know before you maybe embark on a new nutrition approach. So you have a baseline before you hop on to hormones. And it's super helpful to know what might be happening that could be preventing you from reaching your goals. I've personally used their Metabolomics Plus test and their GI effects test. Both were so instrumental in helping me work with my physician with actual data that allowed for me to improve my health when I was dealing with a chronic illness at the time. And thanks to a lot of their testing, I was able to get useful information to take actionable steps alongside my doctor to, feel better, which I do. I'm back to my optimal self. So I am so excited to share that Genova Connect is offering you 15% off any of their test kits when you use the code MetabolicLink at gdx.net/themetaboliclink. That's code MetabolicLink for 15% off at gdx.net/themetaboliclink. Now off to our episode with Dr. Philip Ovadia. Dr. Philip Ovadia, thank you so much for joining me on the Metabolic Link podcast today. It's so great to have you here.
Yeah, it's always great to see you again, Victoria. Love all the great work that you and the team are doing over there, and happy to be a part of it.
Thank you so much. And we feel the same as, you were just doing phenomenal work. I know we just talked about you performing heart surgery this morning and then jumping on podcast. You're so dedicated to your work, and it's truly inspiring to watch. And I'm really excited to dig into the conversation today because, you're a board certified cardiac surgeon who has performed thousands of heart surgeries, I think at this point, over 2 decades. And you're likely really the closest to the true gravity of the heart disease epidemic compared to any other physician, right? You're seeing people kind of at possibly for some, the end of the road when, emergency intervention is needed. Heart disease is the number 1 killer in the United States, as you well know, and worldwide. And I think it takes something along the lines of 700,000 people's lives every year. So this is really just a truly challenging problem. And I know I've heard you say so many times that you see patients on the operating table, and this is a failure of the medical system. And I would love to start out by hearing more about that and sort of your perspective around that, because this is quite a unique perspective for a heart surgeon. And I'd love to know how you kind of came to this perspective over the course of time, because I know this is very personal for you along the way.
Yeah, the unfortunate reality, all those statistics you shared are true, and maybe even understate the magnitude of the problem. Here in the United States, every 13 seconds, someone has a heart attack. And one out of every four deaths here in the United States is due to heart disease. And heart disease probably contributes to even more of those, because we have to realize that even people who develop cancer or Alzheimer's disease or, diabetes that they die from, heart disease can be a part of that problem as well. And what really sort of, I guess, at this point upsets me is that we declared war on heart disease back in the 1950s. It was actually, most people talk about President Eisenhower having the heart attack while he's in office, 1955, as kind of the seminal event. But it turns out that, the war on heart disease was started even before that. 1949, it was recognized that heart disease was becoming such an increasing problem here in the U.S. In the early 1900s, it's basically undescribed. Doctors don't talk about heart disease, angina, having heart attacks. These things are incredibly rare, and for reasons that no one quite knew, it was accelerating and became a major public health issue. And here we are 70 years later, and it's still a major public health issue, still the number one leading cause of death here in the US and worldwide, like you said. And, during my, I would say, early career as a heart surgeon, I, like most doctors, didn't really think about why is there so much heart disease, right? I was, blessed to be able to help people that were stricken with heart disease. Doing heart surgery can improve patients' quality of life, can extend their life. In many situations, is an acutely life-saving procedure, and I was just kind of happy to be able to do that. But at some point, and it interacts with my personal health journey. At some point, I started asking, why do so many people have heart disease? Why is there a shortage of heart surgeons in the United States today? It's not because we don't train enough heart surgeons. It's because there's too many people that are sick with heart disease. And I started to kind of recognize and awaken to what was before me, that the people that I'm operating on, they really should never make it to my table. We can prevent heart disease. We can diagnose it earlier and manage it more effectively, and they shouldn't need to make it to my operating table. And so that's kind of been the way that I've refocused my mission over the past decade or so as I've been going through this journey.
Yeah, it's been quite the journey to hear. I mean, for you, this is a very personal journey. You lost over 100 pounds. You were morbidly obese at one point. Struggled, I think, with weight over the course of time. Found, I think, a lot of the literature around low carb diets, ketogenic diets, things along those lines. I know you followed mostly an animal based approach to start, and that experience. I'd love to hear, I mean, because you go straight into, performing heart surgeries and kind of saving people's lives. And you talk about how you kind of at one point were like, why is this happening? You had this whole transformation yourself. What was that like for you? I guess in sort of the feelings around and towards this your career and that shift, I can imagine. And maybe the people that you work with and other physicians that you interact with, I can imagine that's affected every ounce of what you do.
Yeah, it certainly has. My personal journey has had this major effect on my professional life. And, what my personal journey sort of opened my eyes to was the fact that there was this alternative thinking out there. I went through medical school, I went through my training to become a heart surgeon. And, I got trained the same way that all the other physicians get trained, right? This sort of standardized thinking around heart disease. And, when it came to heart disease, I was educated that cholesterol was the cause of heart disease. Dietary cholesterol, saturated fat in the diet were the problems. And, and the whole paradigm around obesity and diabetes was eat less, move more, follow the food pyramid. And when, I ultimately had to start doing something different to overcome my own health challenges, right? My own obesity, my pre-diabetes. And I started coming across this information about low carbohydrate diets, about insulin resistance and metabolic health. None of which was really emphasized or taught, during my training. That is what kind of opened my eyes to some of the failings of the medical system. And I had to start asking questions like, why didn't I know about this? Right?
Yeah.
Why isn't insulin resistance, which is clearly a much bigger risk factor when it comes to heart disease than elevated LDL cholesterol is? And why was it never talked about? Why had I only kind of heard about insulin resistance as a sort of biochemical pathway, early on in medical school? And here I was dealing every day with patients with heart disease, and heart and insulin resistance is never mentioned. And those are the types of, conundrums, I guess you could say, right? That I started to see and I started to think about. And one led to another. And it really led me to conclude that our whole paradigm around treating heart disease is a failed paradigm. Because again, here we are 70 years after we started down this pathway of, low fat diets and lowering cholesterol, and just the whole thinking around cholesterol being central to the cause of heart disease. And yet, we're not making an impact. We are losing the battle against heart disease. Heart disease is not only the number one killer here in the US, but it's actually getting worse instead of getting better. And, I, as a physician, couldn't really deal with that. I couldn't accept that. I know that we can do better as a society, as health practitioners. And so that's why I'm obligated to do better, to speak out, to talk about this, to get this more widely known, so more people can stay off my operating table, as opposed to me having to do, that major surgery on them.
Yeah, it's kind of I'm sure been an infuriating process throughout the course of your journey. And maybe let's dig into cholesterol a little bit, because I'm sure that's what a lot of people listening are going to want to know a little bit more about. Because as you've mentioned, it gets this bad rap, right? There's this sort of blanket statement of good versus bad, and it's a very simplistic way of looking at this. But when you peel back the layers, it's quite a bit more complex than that. And there's actually a beautiful role for cholesterol in the body. And so maybe we start there and kind of share a little bit more around your thoughts of the breakdown of cholesterol in terms of quality and quantity, and why those things matter when we're looking at this and overall risk.
Yeah, definitely so. And what you said is probably the first thing that people need to understand, that our view of cholesterol within the medical system is too simplistic. Cholesterol is a very complex molecule. It plays a lot of important and vital roles in our body. And this, misconception that it is only there basically to damage, to build up as plaque in our blood vessels and ultimately lead to things like heart attacks, is simply wrong. And I think it's intentionally simplistic, because it's a lot easier to just make blanket statements like everyone should have lower cholesterol than really get into the nuance of, cholesterol is problematic because of the environment that it's in.
Right.
And the unfortunate reality is this is another example of a concept in medicine that got basically hijacked by the pharmaceutical industry. And when we developed pharmaceuticals that could effectively lower cholesterol, that became the central focus. But we knew way before that, and we know today that it is not that simple. And cholesterol is not always problematic. And cholesterol is actually vital to our survival. We literally could not live without cholesterol. So this concept of, wipe it out, lower it as much as possible is flawed on that level. And, cholesterol is part of the process that leads to heart disease, but it's not what incites heart disease. It is not the root cause of heart disease. And, anyone who kind of knows about problem solving in general knows that you need to identify the root cause first to be able to solve the problem. If you're only focused on sort of downstream steps in the process, you're not going to have great success, no matter what area of life we're talking about. And it's no different with cholesterol. Cholesterol is a downstream player in the heart disease process. And we need to go back and look at what are the true root causes. And that's when we start talking about insulin resistance and inflammation. And if we're going to have a real impact on heart disease, these are the things that we need to focus on.
Absolutely. I mean, just, targeting cholesterol alone is sort of like blaming the firefighter for the fire, as some people have suggested.
Exactly.
Yeah.
And
Go ahead.
and I was just going to say, and the other problem is that we don't get a complete picture of, what cholesterol is, what types of cholesterol are really in people's bodies, and what effects those have, right? We have this simplistic measurement, LDL cholesterol. And then, maybe the more advanced physicians and lipidologists these days will talk about ApoB. But those are both still looking at particular markers of the type of cholesterol carrying particles. And they're not really getting into the detail of, are they actually problematic particles or are they not? Because whether you look at LDL or you're looking at ApoB, they can be problematic, but they're not always problematic. And this is something else that gets lost in the conversation. Again, this sort of public health simplistic approach of just saying it's all problematic and therefore we need to lower it as much as possible has led us down the wrong pathway in many different ways. And it's the reason why I don't think we haven't been able to meaningfully impact the incidence of heart disease and get it out of that number one spot, which ultimately should be all of our goals.
Metabolic therapy is an incredibly exciting area of research. Metabolism is just so critically important to really every aspect of our health and well-being. What's equally as important as the nutrition approach that we follow is the food quality and the nutrient density of what we're actually eating, right? That's why I am so incredibly excited to share that we've partnered with Maui Nui. Maui Nui offers 100% wild harvested meat that's completely stress-free and responsibly sourced. Maui Nui's mission is actually to solve a critical environmental problem in Hawaii to balance access deer populations. You may not know this, but wild access deer are actually invasive to Maui and overpopulated and damaging the ecosystem there. And Maui Nui is the only operation to wild harvest these animals in a way that benefits our environment, communities, and food systems. What's more, and what I love most, is that this wild harvest stress-free process delivers the highest protein to calorie ratio, up to 53% more than grass-fed beef. And their meat and actually sugar-free peppered meat sticks are delicious and pack 10 grams of protein at just 55 calories. Maui Nui's meat is perfect for anyone looking to elevate their meals with delicious, high quality protein, and they're actually offering our listeners of the Metabolic Link a limited collection of our favorite cuts and products. But supply is super limited by just the nature of their work, so don't wait. Head on over to mauinuivenison.com/metabolic link to secure your access right now. Again, that's Maui Nui Venison, MAUINUIVENISON.com/metabolic link. Head on over, check them out, and let us know what you think. Now back to our episode. I'd love to hear a little bit more about, you see patients on the operating table, and you've got a great, I'm sure, history on them in terms of what their cholesterol looks like. How many of these people have, the traditional high LDL, low HDL, that sort of, I guess, simplistic view when they make it to you? And I'm curious too, how do you approach more advanced lipid testing, and the NMR lipo profile test and whatnot? But I'd love to hear what you're actually seeing in these patients that do wind up on your operating table.
Yeah, when we go back through the historical literature in the pre-medication era, right, before we had statins, what the studies from then show us is that about half of the people who ended up having a heart attack were, ending up needing bypass surgery had what was considered elevated cholesterol. So that's one data point that we can look at. When I look at the patients that end up on my operating table today, the reality is that the majority of them are on cholesterol lowering medications. Many have been so for long periods of time.
Right.
And again, LDL cholesterol by itself really does not predict the incidence of heart disease or not. Again, what does predict the incidence of heart disease, what has been found to be the most meaningful marker is insulin resistance. And this, we can go back again to the data before we had all this focus on cholesterol, and we can find the studies that support that. And even today, the few studies that choose to look at it anymore, they all pretty consistently show that patients with heart disease almost universally have insulin resistance. Whereas high cholesterol, it seems to be a coin flip, 50-50 shot. So, my kind of plea to my colleagues ultimately is let's look at the insulin resistance. You want to look at cholesterol also, fine, we can talk about that,
Right.
but don't ignore what is the major problem, the elephant in the room, which is the insulin resistance and metabolic disease.
Yeah, that's a really great point. I'm glad you're also encouraging your colleagues to to look at the similar things. So, what are the key, I guess, ways that you assess a patient in terms of, true atherogenic risk when you're looking at, maybe some blood markers? I'd love to know. Obviously, you're speaking to insulin resistance, but maybe speak to markers specifically, and what kind of gives you a better whole person view of where this person might be headed and whether or not they could do something about it along the way.
Yeah. So ultimately, from a blood work perspective, what I look at three areas, right? We have insulin resistance, we have inflammation, and we have the type of cholesterol that they have, right? Not the amount, but what type of cholesterol that they have. So, when we look at insulin resistance, there are a few different ways that we can assess this, right? We can start simply hemoglobin A1C, fasting blood glucose levels, and your fasting insulin level. We can get a little bit more deeper, right? We can look at a HOMA-IR score, or probably my favorite marker these days is what's called an LPIR score, lipoprotein insulin resistance score. And what's unique about this marker is because insulin is so powerful of an effector of the type of cholesterol particles that people have, we can work backwards and we can look at that advanced lipid panel and we can look at the sizes and the distribution of their lipid particles. And we can actually work backwards and figure out how insulin resistant they are. And that's a great marker if people have access to it. there are some other simple things that I point people to, right? The triglyceride to HDL ratio that gets, talked about more these days. And that's an indirect indicator of insulin resistance as well. Conceptually, right, you want low triglycerides and high HDL cholesterol, which is reflective of good metabolic health and of not being insulin resistant.
Right. Go
Um,
ahead.
so those are, those are the different ways that we can figure out insulin resistance ultimately. And you definitely want at least one of those, right? Or some of those to kind of give you a picture. Um, then we move on to the inflammation. C-reactive protein is a great marker. There are some other ones like the sedimentation rate, the ESR, IL-6. C-reactive protein, I find, is a pretty good one. And it's interesting because C-reactive protein has become increasingly focused on as a risk factor for cardiovascular disease. There is now a medication that is approved to treat people with elevated C-reactive protein and heart disease.
Wow.
That medication is an anti-inflammatory medication that was, more commonly used for things like gout and other inflammation disorders. But that medication now is approved to lower the risk of heart disease. And it turns out that in patients that have elevated C-reactive protein and heart disease, that medication, colchicine, is as effective as statins in reducing the risk of. This was studied in the secondary event field. So this is people who already had a heart attack, preventing a second heart attack. It was as effective as statins have ever proven to be. So that shows us the role that inflammation plays in heart disease. And then finally, when you get to the lipids, right, it's not about how much cholesterol. It's not about what is your LDL level or your ApoB level. You really need that advanced lipid panel, the NMR panel, it's called, to show you what the particles look like.
Mm-hmm.
And specifically, we know that the atherogenic particles, the ones that actually get in the plaques and, contribute to the buildup of these plaques in the blood vessels, are the small, dense LDL particles, and then your VLDL particles and your IDL particles, which don't get as commonly measured. But when you look at those, right, that can give you the answer as to whether or not someone with an elevated LDL level or an elevated ApoB level should be concerned or not. Because if your ApoB or your LDL level is elevated because you have mostly large LDL particles, you don't need to be worried about that situation. That's a good situation. Your body is using the cholesterol as it should be used, and it's doing all the good things, that cholesterol does in our bodies. But because most doctors don't check that, they don't know, right? If they're just looking at a high LDL level, they don't know, is it problematic or not? And the default is to assume it's problematic. And there are reasons for that, and that's valid, because most people are insulin resistant in society, and therefore most people are going to have problematic particles. But for the people who have discovered metabolic health and they're doing, for instance, a low carb or carnivore type diet, and their LDL cholesterol goes up and their doctors are freaking out and telling them that this is a bad diet for them, this is the data that they need to, prove to themselves and their doctors that it's not a problematic situation and it's actually our bodies operating in the way that they're supposed to operate.
Right. That's a really good point. Actually, one that I've personally struggled through. Being a lean mass hyper-responder myself, as I'm sure you're very familiar with, Dr. Nick Norris, Dave Feldman, their work around lean mass hyper-responders. Would love to hear, though, maybe we back up for a second, what you've seen with patients when it comes to specific improvements around heart health. if your patients have adopted a low carb or ketogenic or animal-based diet, what are you seeing? Because I know now your practice is focused heavily on this, and I'm sure you've seen all kinds of amazing results, as well as lean mass hyperresponders along the way.
Yeah, definitely so. And the most important thing that we see is this reduction in inflammation, the correction of insulin resistance. And from a blood work standpoint, those are the goals that we're going for. And honestly, if people are able to adhere to, the diet and the lifestyle, it's almost universal that occurs. If it doesn't occur, we really need to start digging to figure out, what else is going on. And occasionally we find some other things that we can certainly talk about. Beyond the blood work, though, the other thing we haven't touched on yet is, the blood work is great. It gives us information about risk factors, but it's not actually measuring the disease itself,
Right.
right? We don't have a blood test that tells us, do you have heart disease or do you not have heart disease? And what's the status of your heart disease? And that's where the imaging comes into play. And things like coronary artery calcium scans and in certain situations, CT angiograms, right? These actually show us what's going on in the blood vessels. And so these are more important in my mind than the blood work is. Now, there's a balancing act, right? You can't get these scans as frequently as you can get blood work. And the response may not be, sort of as quick as you see on the blood work. So ultimately, I use both in my practice. But what I'm seeing more and more is people that when they improve the blood work, when they correct the insulin resistance, when they lower the inflammation, when the types of lipid particles that they have improve, the heart disease, as seen on the images, stops getting worse, which is our primary goal. And in many cases now, more and more cases, I would say, it's getting better. We see calcium scores going down. We
Mm.
see evidence on CT angiography of, uh, you know, plaques regressing and blockages lessening. And then,
Wow.
and that's great. Ultimately, what I tell people is my goal is to make sure it doesn't get worse. And if we get improvement, even better.
Yeah, that's pretty amazing because, talking about the reversal of atherosclerosis is kind of, I don't know, sometimes a little controversial. Like people get a little, when you're talking about lifestyle, completely reversing some of these things. I'd love to hear what you've actually seen as a cardiac surgeon in this process of implementing lifestyle. Can we reverse heart disease? And I think it's something along the lines of 90% of heart disease is actually preventable. But what does it look like when it comes to reversal in the field, as a physician yourself, seeing hearts face to face?
Yeah, no, I mean reversal is definitely possible. And again, this is controversial, right? This is shocking to most doctors in the same way that, we go back 10, 15 years ago and you say that type 2 diabetes was reversible and no one really thought that was possible, but through some of the great work of Verda and Sarah
Yeah.
Hallberg and Jeff Volek and Steve Finney and all of them, right? They have now proven definitively that type 2 diabetes is reversible, and they've published the literature on that. And that's, and now, although a lot of doctors still don't believe it, right? We have the proof. And I'm seeing the same thing in my practice now when it comes to heart disease. I'm routinely seeing people, like I said, my goal is to stop it from getting worse. And this is an important concept, right? Because we know that heart disease is a progressive disease. You don't go from no heart disease to my operating table in an instant, right? There are rare circumstances that occurs, but generally this is a gradual buildup over time. And that's important, right? And one of the other failings of our medical system is we don't really detect heart disease. We don't think about heart disease until it's a problem, right? Until you have the heart attack, until you start having symptoms. So, one of the other advantages of the CAC scan and the CT angiogram is we can now see the disease at its early stages. And if we could detect it early, and if we can give people good advice, right, we can stop it from getting worse. And it will never get to that point where you're going to need a stent or you're going to end up on my operating table. And so that's the goal in my, preventative practice these days is people come to me, quite frankly, at all stages of heart disease. Some of them have already had the heart attack. Some of them had stents placed. Some of them have had bypass surgery. And no matter where you're starting, right, the goal is the same. Let's just stop it from getting worse. Because the other, what I consider to be a failing, again, of our medical system is we just accept that heart disease is progressive. And, we try and slow it down, sort of, but no one really thinks about stopping it and reversing it. And that is possible. And we're doing it with these diet and lifestyle interventions. And again, it's because we're addressing that root cause, the insulin resistance, the inflammation. And when you address that and you stop what's driving the heart disease, you can arrest it and, prevent it from getting to these advanced stages that I normally see on the operating table.
Have you ever had a weird symptom and instead of maybe booking an appointment with a doctor, because that, who wants to go through that whole hassle, you go to Dr. Google or maybe Dr. Chat GPT? Yes, I know I am super guilty of this and have put off going to the doctor like all of us, but you can actually take charge of your health in a really, really easy way. Find a solid physician who's a good match for you and help you get the care that you actually need by going to ZocDoc. ZocDoc is a free app and website where you can actually search and compare high quality in-network doctors and click to instantly book an appointment right then and there. You'll have access to booking an appointment with a choice of more than 100,000 doctors across every specialty. And you can even filter based on who might take your insurance, who's located nearby. Plus, my favorite part in particular is that you can actually see whether they're highly rated by verified patients, which is huge because who wants to waste their time with a physician that's not a great fit for you? It's really difficult to find a good doctor sometimes. So once you find the right doctor, you can actually see their schedule right there, their appointment openings, and choose a time slot and instantly book. Makes it super easy. So stop chat GPTing what your symptoms are or Googling or whatever the case may be. Stop putting off that doctor's visit. Head on over to ZocDoc.com/metabolic link to find and instantly book a physician today. That's ZocDoc, ZocDoc.com/metabolic link. Back to our episode with Dr. Philip Ovadia. So, a lot of people go walking around or just thinking they're heart healthy enough, right? They maybe follow sort of a standard American diet, or maybe they follow the food pyramid, or whatever the case may be. They think they're doing all the right things. So what suggestions would you give somebody maybe in their 30s and 40s? I know you talked about getting a scan, whatnot, but 30s and 40s, when really people should start to be thinking, if not even before then, should start to be thinking about how to make strides in the right direction to make sure they don't end up on your operating table. What can those folks do now? And I'd love to hear what your thoughts are around that.
Yeah. So my first piece of advice is go ahead and get that CAC scan.
Yeah.
And you're right, 30s and 40s, it sounds young, but this is one of the other major changes that I've seen over my 20-year career is, I now routinely see 40-year-olds ending up on my operating table. That was unheard of when I started my career, not that long ago. And now it is commonplace. And so, many people in their 30s, that means are already well on their way along this process. So get that CAC scan, find out where you stand in regard to your blood vessels, and then figure out if you're insulin resistant or not, right? That's the big one.
Yeah.
So ask your doctor, ask for some of these tests that we mentioned earlier. And if your doctor doesn't know how to assess for that. And the unfortunate reality is that a lot of doctors don't. It's not something that gets emphasized and taught in medical school. And if they don't know, find another doctor, right? And that always sounds harsh, But the reality is, insulin resistance is not only about heart disease. This is something else important for people to understand. We go down the list of the top 10 causes of death in the United States every year, and 9 out of the 10 of them are attributable to insulin resistance, right? You
Yep.
look at all the people that are in this community, and all the types of doctors that you've had on this podcast, right? You have heart disease, you have cancer, you have psychiatric conditions, you have the kidney, you have the endocrinologists that are focused on diabetes. All of these things are related to insulin resistance.
Yeah.
So, yes, of course, I tell people, right, go find out if you're insulin resistant so you can know about your risk of heart disease. But you really want to find out if you're insulin resistant to know about your risk of disease in general, and address it. So at this point, I don't know how you can adequately, uh, perform as a physician if you can't figure out if your patients are insulin resistant or not.
Right. That's a really good point. I mean, we don't even have fasting insulin as a marker yet in a sort of a standard. We're looking at things like blood glucose, where, that's something that you won't see insulin resistance, maybe the trickle down effect of that for years to come. So that's a really important thing that I think people need to keep in mind, is that you have to be an advocate for that, and you for yourself in really learning insulin resistance, because that's not something that is that the thing that first comes to mind, right? You and I know that metabolism is this underlying common thread throughout these diseases, but it's unfortunately not something, insulin resistance is not something that's first looked upon when maybe you're dealing with something like the potential of a cancer diagnosis or heart disease risk or things along those lines. So it's something that you really have to be an advocate for yourself for. So that's a great point. When do you believe lifestyle changes should be prioritized over invasive procedures, and vice versa? Like, where, I'm sure there's like a line between these two things. Like, when can you move forward with a lifestyle change, and when is it like, okay, we need to go in and figure this out?
Yeah, I mean, we do have to face the reality, right? If you're having symptoms of heart disease, if you're having a heart attack, certainly, right? Fixing your lifestyle may not be the priority, right? And that's when the procedures become necessary. And listen, I'm not here to disparage, right, doing heart surgery and putting in stents. They are life saving. They are life
Right.
changing, and when they're needed, they're needed. What I hope people understand is, in addition to the procedure, right, you need to address what led to the heart disease in the first place. And this is where I feel like I have become a better physician, a more rounded physician, right? Because I can say to my patient that's, coming to me for heart surgery, I can say, listen, we're going to do the heart surgery. We're going to address the problem that's ahead of us. But the heart surgery doesn't change what led to you getting here in the first place. And the unfortunate reality is that the people that have heart surgery, for the most part, they still die of heart disease.
Mm.
They die years later. And again, we've improved their quality of life and we've extended their life, but they still die of heart disease because no one addresses what was leading to the heart disease in the first place. And they get this false kind of security that, okay, you had a stent placed or you had your bypass surgery and the problem's taken care of. And,
Right.
you can take this medication like the statins, and that's taking care of the problem, and it's not. And so they still end up dying of the heart disease. And now, again, I can say to them, listen, we know what caused this, and we can address that. And this is how we do it. And that's where the diet and lifestyle comes into play. If you haven't gotten to the point where you're having symptoms and you're having that, right, and maybe your CAC score is high, that is an ideal time to start paying attention to the diet and the lifestyle, because as I said earlier, I now regularly see people that are doing that, and we've stopped the heart disease from getting worse. And I can be confident that as long as they keep doing it, right, that's the challenge, around diet and lifestyle is you got to keep doing it. But if you do keep doing it, the reward is you won't need to come and see me as a surgeon, and you can stop this from getting to that point. And so, diet and lifestyle should always be part of the equation, but it doesn't always, it doesn't take the place of needing the intervention, needing the procedure, if things have already gotten to that point.
Right. That's good advice for sure. And I'm sure I can't imagine what you see on a day-to-day basis as a surgeon. I'm sure you've seen all kinds of things, and especially as you've transitioned to this more, lifestyle prevention approach with many patients. I would love to hear maybe if you have a specific story to share of a triumph that you've managed to help a patient through, and maybe one of the most challenging. I've heard you speak to some of the stories that are pretty devastating of younger people dealing with heart surgery and losing the battle when maybe it could have been prevented. So I'd love for you to share for our listeners maybe some personal stories on both sides.
Yeah, and the tragedies, I guess, that are always part of this, right? When you're doing heart surgery, these patients are very sick and they oftentimes have advanced disease. And so, unfortunately, we can't save all of them.
Yeah.
And I would say over time, maybe the tragedies have become a little bit more tragic to me because I'm aware of how preventable this is and should be. And so, the story, for instance, that's the opening chapter of my book, about, a young mother who, we couldn't save. She came with devastating cardiac conditions. We couldn't save her. And, this was one of the sort of seminal events that really, I would say, propelled me to getting into the more preventative space, because I know in retrospect she could have been saved if things like insulin resistance had been addressed years before.
Yeah.
And now, I am very excited and proud and happy to see in my practice all the time the people who, they come to me with fairly significant disease, but it hasn't gotten to that point yet where they need something done about it. And we are starting to see the scores go down, right? The CAC score go down. We're
Right.
starting to see the CT angiograms improve and their
Amazing.
percent blockages go down. And that is very exciting to see and very rewarding. And, what's most rewarding about it is it's not something that I've done, right? It's not that I had to go in there and do surgery. This is what they've done.
Yeah.
Me and my team have provided them with the guidance, but we've empowered them to take control of their health. And they now know that as long as they keep doing this, right, and as long as they are kind of remain adherent to these diet and lifestyle changes, that they are in control, that they can keep their disease from getting worse.
Yeah.
And that ultimately is the most rewarding thing to me as a physician, right? Because it's not about me doing it for them; it's about them doing it and them being in control.
Right.
And it's definitely a different way of looking at things as a physician, right? You're trying to get people to the point that they really don't need you.
Right.
But in my mind, that's the ultimate. That's success. That's a win. And nothing's better to me than when I'm able to say to that patient, "Listen, you really don't need me any longer." Now, a lot of them thankfully choose to keep working with me, and we keep doing check-ins and stuff. We want to keep an eye on things, but I've now empowered them to take control of their health.
Which is amazing. And that's to me truly what medicine is all about or should be all about, right? I mean, you're doing something, unfortunately, that not many physicians can or maybe have the education around to do because nutrition and nutritional intervention and lifestyle and those things are not heavily taught, in medical school. So the fact that you're providing this information is leaps and bounds, ahead of what so many others, unfortunately are not doing at the moment. And that's why what we're trying to, how we're trying to change things over here as well, in providing medical education around this information. Speaking of education, how do you navigate both with the patient and maybe your clinician colleagues, the conversation around fat and heart disease, because it's a very sensitive one. I mean, even, my own family, heart disease is unfortunately something that's in my family. And having that conversation, even with medical providers, is a challenge. There's a heavy push on the vegetarian, vegan side, low fat side, still to this day. I'd love to know, because we do have a lot of medical providers listening to this podcast and patients. It'd be great to hear both sides of the spectrum. Like, how do you approach that conversation to really make the message heard that, hey, this is actually, there's evidence around this. I would love to hear your thoughts, because that's such a challenging conversation to have.
Yeah, it is challenging. And, challenging dogma is always, a
Fun.
battle.
Right.
Right. Yeah. No, I think it's fun too, but
Yeah.
it's always a battle. And, on a high level, right, I just, to my colleagues, right, and to the patients as well, I say, look around you, is this working? Right.
Yeah.
We've been talking about, we've been promoting this low fat kind of centric approach for quite a long time now, right?
Yeah.
We have the macro evidence, right? We eat less fat than we ever did, less saturated fat than we ever did. Our cholesterol levels are lower on a population basis than they ever have been, due to the combination of the pharmaceuticals and the dietary advice. And heart disease isn't going away; it's
Yeah.
getting worse. So, that I think when you get people to really think about that, they realize it. The patients, honestly, it's not challenging. They
Mhm.
intuitively, I think, recognize, right, that it, and when I tell them, like, you don't have to worry about eating eggs or eating red meat, they're like, great, that's what I want to eat. That's what I have been eating. And it never made sense to me that was what was causing the problems. So the challenge with the patients really becomes, again, there are other doctors that may not be as well informed about this stuff, and when they see the high LDL cholesterol level, and they kind of freak out about that. And that's, again, that's when I can step in and you know point to the more advanced data, and explain to maybe the other physician about what we're looking at and what we're doing. uh I think, as a physician, when I'm dealing with my colleagues, more and more, my colleagues are recognizing the failures, right? They're saying, why are all my patients, on these medications, and I've been giving them this advice, and yet, I'm still sending them over to you to do heart surgery, right? They're
Right.
starting to wake up to that. One of the sort of, I guess, the one of the new controversies, right, is around the GLP-1 inhibitors, these new
Right.
medications. But one of the interesting things about those medications is one of the ways they work is by addressing the insulin resistance. So
Right.
it at least kind of starts to open up that conversation around insulin resistance. And, for the most part, when I do lecture to other physicians and I give things like grand rounds, I think in a lot of ways they're excited to kind of hear about insulin resistance as another, important factor in heart disease, because it does give them something else, right? They have become frustrated because putting patients on more and more cholesterol lowering medications just isn't working.
Yeah.
So when you say, hey, there's this other thing, there's insulin resistance, let's start to focus on that. That empowers them as well. And
Yeah.
this is how I think we start to change the narrative, how we start to change the conversation. And it is starting to change, right? You and I are both seeing, right? We go to the meetings, we see more and more physicians there.
Yeah.
The community that you've built has continued to grow. And it's always great seeing all the different types of physicians that come to this.
Yeah.
And the patient movement is growing, right? The patients that are interested in this, and they're starting to force their doctors to open up
Right.
their eyes to this. Because when a patient shows up to them and they've stopped 4 blood pressure medications, because they don't need them anymore, right? And they've lost a ton of weight, and they're telling the physician, I feel better than I ever have. right?
Right.
And if the physician is then going to try and say, well, but this one number, doesn't look like we think it should look, and you got to stop what you're doing, right? That doesn't fly with the patients. And I think even the physicians, kind of feel silly at that point, and maybe
Yeah.
they start to think about, okay, maybe this one number isn't what I thought it was.
Yeah. Yeah, absolutely. That's a good, that's a good point. When everything else feels right and looks good, it's like you got to see the whole tree, not just this like single branch of it, right? You mentioned briefly GLP-1s, which is something that is a very hot topic at the moment. And I feel like so many people, of course, are, well, unfortunately, the majority of our country is metabolically unhealthy. So it's no surprise that you've got quite a lot of people gravitating towards this. But there are some things that are potentially problematic around GLP-1s too, muscle mass, a variety of things. I'd love to hear your perspective on them, maybe with folks who are already at high risk for heart disease, and what your opinion is of continuing them long term, short term. How do you approach this topic?
Yeah, it's kind of like what we touched on earlier, right? It can't be the whole solution to the problem.
Right.
I see the situations where it can be a useful tool, but it doesn't solve the problem ultimately, right? It doesn't correct the underlying things that led to that person becoming insulin resistant, and it's not a lifelong solution, right? When we're dealing with patients in their 20s and 30s and 40s, to say, well, you're just going to take this medication for the next 60 or 70 years. I don't want that to be the answer for any problem, right? There may be very rare circumstances where there truly is no other option, but this is not one of them.
Yeah.
And so I think if they're used properly as an adjunct, if we really are introducing patients to the diet and lifestyle changes that are going to be the meaningful long-term solution, then I see a role for them.
Yeah.
But I don't want, and I never would tell my patients that, just take this medication, don't worry about anything else, and it's going to solve your problems.
Right.
And unfortunately, I think that is how it gets used all too often.
Yeah.
Physicians have actually been sort of poisoned against diet and lifestyle, right? Because we were educated on giving bad advice, and
Mm.
that bad advice didn't work, right? Many physicians have this sort of misconception that diet and lifestyle doesn't work.
Yeah.
But, as you and I and many others have seen, when you give the right diet and lifestyle advice, it does work and it is sustainable. And and yeah, the medication can be an adjunct for some people that are really starting from a bad place, and it can give them that little kickstart and give them some confidence while you're implementing the other things, with the goal of, we're going to get you off of this, over the long term.
Yeah, that makes a lot of sense. Using it as sort of a piece to the puzzle, but lifestyle is so important. Resistance training, all of these things to keep a solid foundation in the process is critical too. So you briefly touched on misconceptions, and I want to hear if there are any misconceptions for you around heart disease and prevention that just you're constantly trying to battle and that you'd like to clear up, because I do think there are a lot of them. And I know you've touched on some of them over the course of this episode, but it'd be great to hear concisely what are the top ones for you that you battle, I'm sure on a daily or weekly basis.
Yeah, I mean, again, the top one is clearly that cholesterol is the root cause of heart disease,
Right.
and it is not. It is not a driving factor. It is not a root cause. Cholesterol in and of itself does not cause heart disease,
Yeah.
and this is a big one, right? And we have many leading physicians, right? And I hear them all the time on the podcasts and giving their lectures, right? And they say that cholesterol is causative of heart disease, and it absolutely is not. And they can, they point to all the advice, right? And all the evidence that they have. And I just turn back to them and say, none of this proves that cholesterol causes heart disease. And we know mechanistically it doesn't.
Yeah.
There is no way for cholesterol to cross an undamaged endothelial, barrier So the first thing is you need to damage the endothelium,
Mhm.
and undamaged cholesterol does not stay in the blood vessel wall once it crosses.
Yeah.
So you need to damage endothelium, and you need damaged cholesterol to actually cause the problem. And that leads us back to the insulin resistance and inflammation.
Yeah.
So, that is likely the one that I'm going to spend the rest of my career battling,
Yeah.
because the old saying that science changes one funeral at a time.
Oh, geez.
That
Yeah.
it takes a long time to change these ideas, but I am seeing there is reason to be optimistic,
Yeah.
right? And I think one of the last things I want to leave people with is the optimism, right? Is the
Yes.
reasons that we should be optimistic, that metabolic health is becoming more into the conversation, more to the forefront of medicine. We have some great young minds like Nick Norwitz that you mentioned, right, that are going to lead, I think, this new wave of physicians that are focused on insulin resistance and metabolic health, and really, turning our eye towards root cause medicine as opposed to just pharmaceutical based medicine. And society as a whole is waking up to this, and we're starting to have the conversation, the national conversation here in the United States on the political levels about this. And so that makes me very optimistic to see what's going on, and very optimistic for the future around all of this.
Yeah, absolutely. I think we keep having these kinds of conversations. You're doing such amazing work in speaking not only to the fellow clinician, but your patients, and it's going to come from both sides, as you mentioned. Hence why we, created a conference that it's inclusive of both sides, because I think there's a big push that's happening on both fronts, and we all got to band together and continue to spread the message around metabolic health. So I can't thank you enough for all the work that you're doing. You've come out with a phenomenal book, Staying Off My Operating Table. For those who have not read it, definitely check it out. And then where else can people find you, and what's coming up for Dr. Ovadia? I would love to hear. I'm sure you've got all kinds of things on the horizon, but would love to hear where people can find you and any information you'd like to share.
Yeah, so iFixHearts is where to find me everywhere. So all the social medias, you can go to ifixhearts.com. My team and I continually are trying to figure out ways of serving more and more people. We have a telemedicine practice that is available across the United States and even internationally now. So invite people, if you're struggling to find a doctor to work with you on this, come, see what my team and I are doing. And if that helps, if that works for you, we are doing group programs, employee wellness programs. We're really just trying to build out more and more options for people. And that's really the mission, right? Continuing to spread this message. If people want to come check out my podcast, also called Stay Off My Operating Table, we're just about to come up on episode 200, a big,
Congrats.
road marker that we're passing. And we're excited about that. And then I end up at many of the conferences as well, and always look forward to meeting people in person there whenever possible. So we're just trying to keep spreading the message here and try and keep more and more people off my operating table ultimately.
Well, you're doing a phenomenal job. And I don't know how you sleep because you have so many things going on, but it's quite impressive. And we truly appreciate what you're doing from the Metabolic Health Initiative side. So thank you for that. And speaking of, Dr. Ovadia is actually going to be on our medical education platform, the Metabolic Initiative, coming up March 31st, 2025 at noon PT, 3 p.m. ET. And this is to basically as a follow-up to this podcast episode, because I don't know about you or those who are listening and watching, but I have 5 million more questions for you. And this is your opportunity to join us live on the platform to ask this incredible physician those questions. So thank you for joining us for that as well, Dr. Ovadia. And again, thank you for your important work. We're really just thrilled to continue to follow along and be a loudspeaker for it along the way.
Yeah, thank you. And thank you to everyone at Metabolic Health Initiative for all that you guys are doing, and excited to be able to interact live with some people next week as well.
Absolutely. Well, thank you so much. Thanks for listening or watching this episode of The Metabolic Link. If you like this episode, be sure to leave us a review. It goes a long way in letting people know about this podcast, because if you truly believe in the science behind metabolic health and therapy, sharing this information by leaving us a review, leaving us a comment, sharing with your friends goes a long way in helping us spread this message. If you enjoyed this episode, I also want to mention that we're hosting a live Q&A with Dr. Philip Ovadia on March 31st at 12 p.m. PT, 3 p.m. ET on our medical education platform. That's at membership.metabolicinitiative.com/Ovadia, Ovadia. And there you'll be able to ask him all the questions that I'm sure have come up over the course of this episode. Live right there on the spot in the chat. And it's going to be a really incredible discussion, because I probably could have talked to Dr. Ovadia for another hour or so. So be sure to join us on that live Q&A. Your first 7 days are free on our platform, and there is just tons of content on that website where you can watch interviews with world experts. You can join live Q&As with leading doctors. You can download our ebooks. You can watch presentations from our conferences. I mean, it's really endless, and we're constantly updating with new content there. Oh, and you can also listen to podcast episodes without ads, and episodes that we don't even release to the public. So head on over to membership.metabolicinitiative.com/Ovadia to join our next live Q&A on March 31st. And as always, thank you so much for joining me, and I look forward to seeing you next time.
Do you love learning about metabolic health? So do we. It's why we created the Metabolic Initiative, an online educational platform providing evidence-based education on metabolic health and therapies for healthcare professionals and the general public. By joining the Metabolic Initiative, you'll gain access to hundreds of expert lectures, interviews, panel discussions, and even private episodes of the Metabolic Link. CMEs are available. Go to metabolicinitiative.com to get started. And as always, thank you for listening to the Metabolic Link.